The next presentation is by Dr. José Jerónimo. He'll be presenting on scaling up visual inspection using acetic acid in low and middle income countries. Now, Dr. Jerónimo is a senior advisor for the women's cancer at PATH, that's based in Seattle. He's also the director of startup project for testing new molecular cervical cancer screening methods. He completed his medical studies in Peru, and before joining PATH, he worked with the National Institute of Health, National Cancer Institute for about 6 years. Dr. Jerónimo has or more than 60 peer-reviewed publications, multiple professional honors, and serves as a reviewer in a number of peer-reviewed journals. He is also a recipient of the Meritorious Award of a Scientific Achievement by the American Society for Colposcopy and Cervical Pathology. And if he's ready, we're going to hear another excellent presentation.
Thank you, Ricky. And thank you for the invitation again to share some of the work we are doing. And talking about some screening option that we have been working for the last more than 15 years now. And at the beginning, it was very challenging to convince people that could be a good option. After these 15 years, now the situation is very different. I think there are no many questions about the health, the value of visual inspection. Now it's time to implement that. It's time to to expand this capacity among several countries. That's the point of this conversation. Basically, what options we have if we want really to create more capacity with visual inspection around the world. Well, yesterday and today, or before, Dr. Muri also mentioned that the health problem related to cervical cancer is a very prevalent disease in many countries. We have new alternative. That's very clear. We are discussing in the last several IPV meetings about this new alternative. And one of the problems we have now that visual inspection still needs a lot of work to expand that capacity. And training, and I'm highlighting here that training new providers is really essential, and it's a challenge that we need to face. And we are working some options in Latin America with other partners that I'm going to show here. When we talk about the problem of cervical cancer around the world, we have the map of incidence and mortality of cervical cancer in different countries, but always helpful to use other comparison in order to have a different view of the problem. And something that has been faced and work in many countries in the last years is related to maternal mortality, death related to pregnancy-related death. It's something that was worked by multiple countries and organizations, new strategies, new approaches, and really we are having a huge success in the reduction of maternal mortality. And when we compare maternal mortality death with cervical cancer death, there are some differences. In Africa, for example, we have still a significant a higher number of women dying of maternal mortality. But we see regions like Latin America where cervical cancer is showing a higher number of women dying of that disease. And we focus our attention in Latin America specifically. And in Central America, the only country where maternal mortality kills more women than cervical cancer is Haiti. All the other countries, in all the other countries, we have the more women die of cervical cancer. And something that I don't know how many of you are familiar with the word in maternal mortality or pregnancy-related death, but when one woman dies of a pregnancy-related reason, there is a huge problem because the doctor involved in the treatment of this patient is called, the director of the center in many places is called, there is a review of the case, and we see that there are more women dying of cervical cancer and nothing happened, basically. In South America, the same picture, all the countries in South America, more women dying of cervical cancer than maternal mortality. And we have a huge work that we, in order to screen women. If we see the target population that are women 30 and older in the planet, we have more than around 1 billion women that we need to reach at some time to provide screening and treatment of the positive. And one of the challenges is the lack of trained personnel for performing pelvic evaluation. Performing pelvic evaluation could be seen as simple, but placing the speculum, exposing the cervix, and doing it correctly is not easy. I observe many colleagues that have a bad time doing that. Also, the other problem is the limited access to treatment. Cryotherapy is a very good option that we are working, but still it's not that much disseminated in the country. There are some challenges that we are going to talk. And also, health workers have other competing activities. They have many other activities, really, and cervical cancer prevention is only one part, and usually is the smallest part of all the activity they have to do. That's why we have to create an approach or a strategy that has to be easy, simple, and really should not take that much time of that health worker. Visual inspection, even though we are working more than 10, 15 years there, with this technique, we have still, that is not that much disseminated in many countries. There are some countries that already implemented in the national plan, for example, Peru, Colombia, we have Bolivia, Nicaragua. In Africa, there are also some experiences. Even India. India was one of the countries where visual inspection was basically started with a much more, many studies at the time, more than 10 years ago. But in India, still visual inspection is very limited to some pilots or some areas. It's not that much disseminated. Expansion of visual inspection and cryo, we have to train providers, and more importantly, we have to face the issue that we need to train trainers. If we don't have local capacity to train others, it's a huge limitation. Also, procurement of cryotherapy equipment is a big challenge. For example, one of the most commonly used cryo units in the United States, we can buy that unit there in the United States for probably $1,200. When we have that same unit in a developing country, can go up to $4,000, almost 3 or 4 times more. That's a huge limitation. And when you have a problem with equipment, there is no technical support in place in the country. Procurement of supplies for cryotherapy is basically the gas. There are not many supplies that you have to have. But still, procuring gas in some places is a challenge, is a limitation. And also, it's important to have updated guidelines. There are many countries where, basically, if you want to work visual inspection and make a change in one country, you have to start changing the guidelines, in addition to the pilots you can implement. Otherwise, the providers, usually, they don't take that new technique if they are not in the recommendations. Some years ago, a few years ago, we started an experience with the National Cancer Institute in Peru and Japaigo, PATH Japaigo and INEN, the local cancer institute, to create capacity for training. And this was, the idea is to have master trainers, a team of master trainers with capacity to go to the different provinces and create more master trainers there. The other goal was to create a validated package of training material, something that, in the way that we all the organizations working on visual inspection, we can talk the same language, have the same agenda, have the same materials, have the same messages, even the same PowerPoint presentations. And we created a visual inspection cryotherapy service cluster. That means that some centers are able to provide visual inspection and cryotherapy. Other centers are able to provide only visual inspection, but they are connected. They support each other. Model implementation materials and follow-up support for newly trained providers. Follow-up was something that was not implemented in most of the countries. And this is the cluster idea. We have health centers. Some of them have visual inspection and cryotherapy. Some of them don't have cryotherapy, only visual inspection, but they are connected. If they cannot solve the problem at this level, they have a hospital, a small hospital close by, where they can refer the patients. If the hospital is not able to solve the problem, have connection with the Cancer Institute. The idea is to create capacity for all the problems related to cervical cancer there. This Training Excellence Center in Peru, there is extensive practice before going to have pelvic evaluation with patients. There is a very validated list of steps that they have to follow before going to have any evaluation of the patients. Also, the work is related. There is a special training for those who are going to be in contact with the population, doing the education at that level. And there are sessions where the students get together in groups and they can discuss cases, and they have all the manuals for that. Clinical training materials, all that was validated for the different organizations and validated in the field. Also, material for dissemination and supportive supervision. And this is the model. Basically, the clinician comes and attends the clinical skill course, and this is a qualified provider for performing visual inspection, but it's not a trainer. Some of them, because they have more skills to talk in public, to train others, they are selected and they come to the training of trainers. This is the clinical training skills capacity. Basically, they are trained as trainers, and they go and do the first training of others under supervision. And there are some steps, but basically at this level, we have already a qualified clinical trainer. And then there are other steps if we get here to the qualified advanced trainer. That means that this person, when he gets here, he's able to train other trainers. I mean, all the pyramid is built in these countries. As successes, we have a validated package of training materials for standard training activities. It's already there. Now we are translating that to English in order to be used in other areas. And really has become a very good source of, for the countries in Latin America. I can show you the experiences in Peru. In Peru, we started in Lima, but now basically we have several groups of trainers around the country, and the government is using that capacity to train hundreds of other providers around all the provinces. Then we went from Peru to other countries. We had experience in Bolivia. That was not part of our project. It was part of a collaboration of the Training Excellence Center in Peru with the CDC and PAHO, that they went to Bolivia and trained others, and Colombia as well, and Nicaragua. This is basically replicating the same capacity there. In Nicaragua, the government was very open to work in visual inspection. We started in Managua. In Nicaragua, the advantage is that they had some experience in the past as well, and now they are training trainers around the country. They are now capacity in different parts of the country to train others. In Colombia, it's a little bit different because the government have a different strategy, basically having visual inspection and BILI, that they have experience in BILI. The BILI is similar to visual inspection, but using iodine Lugol. And they are using visual inspection in some parts of the country where they have the most challenges for providing services for cervical cancer prevention. And they have other alternatives for the other part of the country. But so far, the experience in Colombia has been very good as well. Cryotherapy equipment, we have some challenges, as I mentioned. The price increases easily from the manufacturer to the final destination in the country. There is a lack of technical support, but we are working with several partners. Japaigo is there, PATH is there, WHO and others, to create some technical specifications about what the machine, what the cryo unit should have. That's already published, I think. It's already there. We are now working with WHO in the creation of the clinical recommendations. Procurement of supplies, I mentioned again, gas is a challenge for procure, and the quality of the gas can be different also from country to country. We see that in some countries it's not that pure and can create some problems in the equipment. And also the amount of gas in the tank could be very different. When you talk to providers, how many cryotherapy you can do with your tank. Some of them say, oh, I can do 40. And you talk to others, say, oh, only 15 or 10 cryo treatments. I mean, I think there could be some difference because the procurement of the gas or the company that sells the gas could have different capacity or quality. Vinegar, something that we didn't expect to face is that vinegar is a supply that is not in the list of supplies that the Minister of Health has. I mean, asking the provider to buy vinegar through the system of the Minister of Health is challenging because there is no item there. In the list of supplies, there is no item they can order and have to be changed as well. Updated guidance, as I mentioned, we are working several organizations with WHO. We are updating the guidelines, the famous pink book that come with the different options for cervical cancer screening. In the previous one, we have basically, the only one was pap smear. Visual inspection and HPV testing was mentioned, but was not recommended, openly recommended. Now in the new guidelines, we see visual inspection is there, HPV testing is there. It should be published around March, hopefully March. That means that this is going to be a very strong tool to go over any country or any place and show that it's not only an experiment or pilot or study, it's something that is recommended for, by organizations like WHO. In conclusion, we have the visual inspection and cryotherapy have shown to be very suitable and very acceptable option for cervical cancer screening in many places. There are several areas that need to be worked for expanding these screening services, and the Training Excellence Center really are a very good resource for expanding capacity on these techniques. The experience can be replicated in other regions. That's what we are trying to do now. That's why the translation of the materials developed in Latin America are undergoing, is happening now. And thank you.